Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a really critical deep dive into primary aldosteronism, PA. It's a condition that honestly is still significantly underdiagnosed in the hospital setting, but it carries these profoundly dangerous implications, beyond just blood pressure for long-term morbidity.
Absolutely. This is a diagnosis that hospitalists, internists, really all of us, we just cannot afford to overlook. Our goal here is to synthesize the latest evidence, looking at the recent AACC and the Endocrine Society guidelines, and distill that down into a clear, structured, and most importantly, clinically actionable approach for diagnosis and management right there in the acute care environment.
And this deep dive is so necessary because the actual prevalence of PA is, well, it's much higher than what we were traditionally taught. Historically, it was seen as this rare cause of hypertension. But the newer data, the contemporary data, show PA counts for maybe up to 10% of all hypertensive patients.
Right, 10%. And that figure gets even more startling when you focus on our highest risk groups. So take patients coming in with resistant hypertension, the ones uncontrolled on 3 or more meds, including a diuretic. The prevalence of PA there just skyrockets. We're talking 20%, maybe even 30% in some studies. That figure alone, really, it should mandate systematic screening in pretty much every resistant hypertension admission.
Yeah, it really should. And the urgency isn't just about how common it is. The real clinical drive here stems from the direct damaging effects of the chronic aldosterone excess itself. This isn't just about poorly controlled blood pressure numbers.
Exactly. Aldosterone acts directly on mineralocorticoid receptors. We find them in the heart, blood vessels, kidneys. And it promotes this profibrotic and pro-inflammatory state in those tissues.
So that sustained profibrotic damage, that insult to the vascular and cardiac tissue, that's the core pathology driving the increased risk,
Precisely. And that translates directly into significantly higher rates of major adverse cardiovascular and renal outcomes down the road. We see much higher risks of atrial fibrillation, stroke, MI, and progressive chronic kidney disease. And crucially, these risks persist even if you manage to get the systemic blood pressure under control using standard antihypertensives, if those drugs don't specifically block the mineralocorticoid receptor. Finding and treating PA, it's really a race against organ damage.
Okay, so to manage this effectively, we first need a really clear handle on the pathophysiology and the classification. Hyperaldosteronism, broadly speaking, it means excessive aldosterone production. That drives sodium retention, volume expansion, hypertension, and then you get that classic triad effect, potassium wasting, metabolic alkalosis.
Right. And we absolutely have to differentiate between the primary and the secondary forms. That's step one. Primary hyperaldosteronism, or Conn syndrome as it's sometimes called, is defined by eponymous inappropriate secretion of aldosterone from the adrenal glands. The key here is that the adrenal production is independent of the renin-angiotensin system. It's gone rogue, basically.
And the biochemical hallmark of that autonomy, the thing that tells you it's primary, is the suppression of renin. Because that chronic excess aldosterone causes volume expansion, right? So the kidney's juxtaglomerular apparatus senses this surplus, and renin release just gets shut down.
Exactly. Inhibited. That suppressed renin is the absolute differentiating feature. You need to look for that.
So when we look at what causes PA, the etiologies, the two most common culprits account for the vast majority of cases, correct?
That's right. Bilateral adrenal hyperplasia, BAH, and the unilateral aldosterone-producing adenoma, APA. That's often a single tumor on one side, and telling these two apart becomes really critical later when we get into deciding on definitive therapy.
We should also just mention the less common drivers. Be aware of them. Things like unilateral adrenal hyperplasia, adrenocortical carcinoma, which is rare but aggressive, and then the various forms of familial hyperaldosteronism, FH types I through IV.
Yes, those familial forms often involve specific genetic mutations, things affecting the KCNJ5 potassium channel or the CACNN1D calcium channel, for example. They usually pop up in younger patients, often with a really strong family history of early hypertension or stroke.
Okay, so that's primary aldosteronism. What about secondary hyperaldosteronism? How does that differ?
Secondary is completely different in mechanism. It's a compensatory state. In secondary hyperaldo, yes, aldosterone is elevated, but it's being appropriately regulated, driven by a trigger. And that trigger always results in elevated renin levels. Usually it's because of a perceived decrease in effective arterial blood volume or maybe reduced renal perfusion.
Right, so you think of the classic clinical scenarios there. Patients with severe heart failure, maybe advanced liver cirrhosis, or even just true hypovolemia. The kidney senses inadequate perfusion, or maybe in renal artery stenosis, actual localized hypoperfusion, and it just ramps up the whole renin-angiotensin-aldosterone system appropriately.
Exactly. The aldosterone is high, but the signal driving it makes sense physiologically. Understanding that fundamental dynamics suppressed renin points to PA, elevated renin points towards secondary aldosteronism. That's the bedrock principle that guides the whole diagnostic workup we need to talk about.
Okay, let's bridge that theory to practice. Let's talk about the clinical clues.
Yeah.
Because as we mentioned earlier, that classic textbook picture, severe hypertension plus spontaneous really low potassium, that only describes a minority of PA patients.
Precisely. And this is probably the single most important clinical concept we need to hammer home for the hospitalist community. The majority of patients with confirmed PA are, in fact, normokalemic. Their potassium is normal. So the absence of hypokalemia should never preclude screening if you have a patient in a high-risk group. Never.
So what are the key features then when PA does manifest clinically, beyond just hypertension?
Well, resistant hypertension is a big one. That's failure to hit the BP goal despite being on 3 or more optimally dosed antihypertensives, and one of them needs to be a diuretic.
Okay, resistant hypertension. What about if hypokalemia is present?
If it's there, it can be spontaneous, or it might only show up after starting a diuretic. Often it presents subtly at first, things like generalized muscle weakness, maybe persistent fatigue, muscle cramps, sometimes paresthesias. But in severe cases, say potassium less than 3.0, definitely less than 2.5, then you worry about the big stuff, life-threatening cardiac arrhythmias, rhabdomyolysis, even acute ascending paralysis.
And we'll often pick up metabolic alkalosis on the BMP, the basic metabolic panel.
Yes, that's due to the increased urinary excretion of potassium and hydrogen ions, driven by that excess mineralocorticoid activity. You might also see secondary signs related to the chronic volume expansion and electrolyte issues, things like polyuria, polydipsia, maybe bothersome nocturia. That can be related to aldosterone-induced damage that actually impairs the kidney's ability to concentrate urine properly over time.
So the ACC guidelines actually give us a pretty useful framework here. They list specific high-risk populations where we should be actively screening. That's a key part of our job as hospitalists, right? Identifying those patients.
Absolutely. Targeted screening is essential. First on that list, and probably most critical, is any patient with confirmed resistant hypertension. Screen them.
Okay. Second
is hypertension combined with any form of hypokalemia. Doesn't matter if it's spontaneous or diuretic-induced. If the K+ is low and they have hypertension, screen.
Third, patients who show up with an adrenal incidentaloma, that mass found, by chance on a CT scan done for something else entirely.
Exactly. And moving beyond maybe the most obvious ones, the guidelines also say screen patients with hypertension plus obstructive sleep apnea. There's a known association there.
That's an important one. And the last group.
And finally, those with a family history of early-onset hypertension or maybe stroke at a young age, say before 40, that really points towards the possibility of one of those familial PA syndromes. Following the systematic approach, studies show it significantly boosts our detection rates. We just have to look for it in the right populations.
Okay, let's shift gears now to the actual diagnostic workup. This is where, the practical challenges of inpatient medicine meet the need for biochemical precision. The initial screening labs rely on 3 key components: plasma aldosterone concentration, CAIDE, plasma renin activity, PRA, and then calculated the aldosterone-renin ratio, the ARR.
Right, and the guidelines give us clear, actionable thresholds for screening, but you have to interpret them carefully, always alongside the patient's clinical context. So a result suggestive of PA generally requires an ARR cutoff of 30, that's using PET in nanograms per deciliter, and PRA in nanograms per milliliter per hour. And importantly, you also need a corresponding PEC that's elevated, usually defined as 10 NGL or greater. You need both.
Okay, AR of 30 and PEC of 10. But we absolutely have to emphasize the prerequisites for this screening to even be valid. The patient needs unrestricted sodium intake, and absolutely critically, their serum potassium has to be normalized before you draw the blood.
Yes, that potassium normalization is so vital. Why? Because profound hypokalemia can actually artificially suppress aldosterone secretion, and that can lead to a potentially disastrous false negative screening test. You can miss the diagnosis entirely. So we need to stabilize those electrolytes first. Ideally, you want to aim for a potassium level above 4.0 MEQL before drawing those screening labs.
And that requirement immediately brings us to maybe the biggest logistical hurdle in the acute care setting: medication interference. So many common blood pressure meds profoundly mess up these results. They alter renin and aldosterone levels, leading to ARRs you just can't interpret. You can't simply run the test while a patient is on their usual, multi-drug regimen.
Let's break down the why of that interference, because understanding that helps guide the substitution strategy. Okay, so drugs that significantly increase renin, think ACE inhibitors, ARBs, diuretics, they will artificially lower the ARR. That could cause a false negative.
Okay, so ACEs, ARBs, diuretics lower the ARR. What about the other way around?
Conversely, drugs that significantly suppress renin beta blockers are the main ones here. They can artificially elevate the ARR. That could lead to a false positive screening result. And then, of course, you have the mineralocorticoid receptor antagonists, the MRAs like spironolactone or eplerenone. They directly block the receptor. And that can cause this rebound increase in both renin and aldosterone levels, making the whole PEG-PRA ratio pretty much uninterpretable while the patient's on them.
So we have to implement a withdrawal and substitution plan. Ideally, those interfering agents, MRAs, ACEs, ARBs, diuretics, beta blockers, they need to be stopped. For how long, typically?
Minimum of 2 weeks, sometimes up to 4 weeks, especially for the MRAs, before you repeat the testing to get a clean result.
Okay, 2 to 4 weeks washout. That's a significant challenge when you're trying to manage blood pressure acutely in the hospital. So the substitution strategy becomes absolutely critical. We need to keep the patient safe while optimizing the conditions for the test.
Exactly. We have to substitute those interfering drugs with non-interfering antihypertensives. The preferred choices are usually the non-dihydropyridine calcium channel blockers, think sustained-release verapamil or diltiazem, or direct mass dilators like hydralazine. Alpha-1 adrenergic antagonists like prazosin or doxazosin are also good options. These agents generally allow for acceptable BP control without messing up the ARR interpretation too much because they have minimal impact on the renin-angiotensin system itself.
All right, so let's say we've navigated the medications, gotten the potassium up, done the screening, and it comes back positive or highly suspicious. What's next?
The next step is confirmatory testing. The whole purpose here is to definitively confirm that autonomous, non-suppressible aldosterone production we talked about. Given the need for efficiency in the hospital, the saline suppression test, or SST, is often the most practical confirmatory test we can do in patient.
Okay, the SST, how does that work?
The procedure involves infusing 2 liters of normal saline over 4 hours. Usually the patient is seated or semi-recumbent to minimize posture effects on aldosterone. Then you measure the PACE right at the end of that infusion. The principle is simple. In a healthy person, that massive volume load should dramatically suppress aldosterone secretion.
But if the patient has PA, that suppression won't happen normally, so how do we interpret the result?
It centers on that post-infusion PACE level. If the post-SST pack is below a certain cutoff, generally around 5.8 to 7.8 NGDL, depending on the lab and assay, then PA is effectively excluded. However, PACE values clearly above that threshold, let's say greater than 10 NGDL, strongly support the diagnosis of PA. The aldosterone wasn't suppressed by the volume load.
What about results in the middle? That gray zone, say between 6 and 10 NGDL post-SST?
Yeah, that's considered equivocal or indeterminate. In that situation, you might need to consider one of the other more demanding confirmatory tests, things like the oral sodium loading test or the fludrocortisone suppression test. But honestly, those are rarely done acutely in the hospital setting because they take much longer, several days usually.
Right, and critically, there are 2 major safety caveats we absolutely have to mention for the SST.
Yes, absolutely crucial. First, as we keep saying, you must correct any hypokalemia before doing the test. If the potassium is low, the adrenals might be artificially sluggish, potentially leading to a false negative SST result, even if they truly have PA.
Okay, correct potassium first. What's the second safety issue?
Second, the SST involves rapid volume loading 2 liters of saline in 4 hours. That carries a significant risk profile for certain patients. It's absolutely contraindicated in patients with poorly controlled, severe hypertension. We usually want the pressure below something like 170/100 beforehand, and especially contraindicated in patients with significant volume-sensitive conditions, think severe heart failure, NYHA class 3 or 4, or advanced chronic kidney disease, maybe a GFR less than 30. The risk of tipping them into acute pulmonary edema is real and must always be weighed against the diagnostic benefit. You have to be careful.
Okay, so we've screened, we've potentially done confirmatory testing like the SST, and we have biochemical confirmation of PA. The next critical step is subtype differentiation. We need to figure out if the disease is unilateral like an APA or bilateral like BAH. This distinction drives the entire management strategy. Initial imaging is usually an adrenal CT scan.
Right. CT is first line. It lets us screen for large masses, look for irregular shapes, or identify features that might suggest adrenocortical carcinoma, like a mass bigger than 4 centimeters, or signs of invasion.
But the critical limitation of CT, and this is really important for the hospitalist planning the next steps, is that imaging alone cannot reliably distinguish between a small aldosterone-producing adenoma and bilateral adrenal hyperplasia. Plus, in older hypertensive patients, non-functioning adrenal incidentalomas are incredibly common, and they can completely muddy the waters.
Exactly, which is why adrenal venous sampling, or AVS, remains the gold standard for subtype differentiation. AVS is required, or at least strongly recommended, in essentially all surgical candidates to pinpoint the source of the aldosterone excess. Is it coming mainly from one side, or is it coming pretty equally from both?
And we need to stress for our audience of physicians, AVS is not a simple procedure. It's technically very challenging, highly operator dependent. It often has a significant failure rate, especially in centers that don't do a high volume of them. So when you refer a patient for AVS, you need to understand that.
Absolutely. Success requires really skilled interventional radiologists who can cannulate those tiny adrenal veins to get reliable samples. We look for two main technical things during AVS to know if it was successful and what it means. First is the selectivity index, the SI. That's the cortisol concentration in the adrenal vein sample divided by the cortisol in a peripheral vein, like the IVC. An SI of 2 or greater generally confirms the catheter was truly in the adrenal vein and the sample is good. If the SI is inadequate, the AVS is non-diagnostic.
Okay, so selectivity index tells you if you got a good sample. What's the second metric?
Second, we look for the lateralization index, or LI. This compares the aldosterone levels between the two sides. It's often calculated as the PI, corrected for cortisol, from the dominant side divided by the PI, corrected for cortisol, from the non-dominant side. This is usually done under ACTH stimulation to maximize aldosterone secretion during the procedure. An LI of 4 or greater typically suggests unilateral PA, meaning the aldosterone is predominantly coming from one side. That patient is likely a good candidate for adrenalectomy.
And sometimes we also look at the contralateral side directly.
Yes, we also examine the contralateral suppression index. If the aldosterone level in the vein of the non-dominant adrenal gland is clearly suppressed compared to peripheral levels, that reinforces the diagnosis of unilateral disease. It also predicts a higher likelihood of biochemical cure after surgery. So AVS is generally recommended for most patients being considered for surgery, especially those over 40 or anyone with unclear or potentially confusing CT findings. The cure rates after adrenalectomy are significantly better when guided by AVS.
Okay, so while this complex diagnostic workup is proceeding, especially if there's a wait time for scheduling AVS, we still have a patient in the hospital who needs acute management.
Yeah.
Our immediate focus has to be on controlling the blood pressure and stabilizing electrolytes.
Right. For BP control, we continue to rely on those non-interfering agents we talked about, the non-dihydropyridine, CCBs, hydralazine, maybe alpha-1 blockers. The goal is to maintain patient safety without compromising any future diagnostic tests, like the AVS itself.
And we have to be aggressive about correcting hypokalemia. If it's severe, say K plus less than 2.5, we often need slow, carefully monitored IV potassium chloride infusions. For more moderate cases, high-dose oral supplementation, maybe potassium chloride liquid or pills, is usually effective.
And the goal isn't just safety, it's normalization. We need to get that potassium up into the high normal range, ideally above 4.0 milliQL, before any confirmatory testing like SST or especially before AVS. We also need to remember that treating the underlying hypokalemia and restoring normal volume status is fundamentally how we manage the associated metabolic alkalosis as well.
Okay, so let's say the workup is complete. We know the subtype. Now we arrive at definitive subtype-specific therapy. For patients confirmed to have unilateral disease like an APA confirmed by AVS, what's the plan?
Laparoscopic adrenalectomy is the preferred definitive therapy for confirmed unilateral PA surgery. The benefits can be really profound. It often results in a complete biochemical cure. Aldosterone levels normalize. It typically resolves the hypokalemia completely, so no more potassium supplements, and it significantly improves blood pressure control. Sometimes it even normalizes it completely off all meds, though that's less common in older patients with long-standing hypertension. But importantly, the data show that surgical intervention offers superior long-term cardiovascular risk reduction compared to just relying on medical therapy alone for unilateral disease.
And post-operatively, what do we need to monitor closely?
Post-op, you watch for immediate blood pressure changes. Sometimes hypertension persists initially, sometimes they can become hypotensive. You absolutely have to monitor electrolytes, particularly for potential contralateral adrenal suppression. The good adrenal might have been suppressed by the high aldosterone from the tumor for so long that it takes time to wake up. This can sometimes lead to transient postoperative hyperkalemia, which might even require temporary glucocorticoid support in severe cases until the other adrenal recovers. And then, of course, you confirm the biochemical cure with repeat PAC and PRA measurements, usually around 6 to 12 weeks after the surgery.
Okay, that's unilateral disease. What if the AVS confirms bilateral disease, BAH? Or what if the patient isn't a surgical candidate for other reasons, like comorbidities or just personal preference?
In those cases, confirmed bilateral disease or non-surgical candidates, medical management using mineralocorticoid receptor antagonists, MRAs, becomes the mainstay of treatment.
Spironolactone is the classic MRA here, right?
Yeah.
Highly effective.
Yes, spironolactone is usually considered first line. It's very effective. We typically start low, maybe 12.5 to 25 milligrams daily. Then we titrate based on response blood pressure. Potassium levels often up to 50 or maybe 100 milligrams daily. Sometimes even higher doses are needed. It's generally very good at correcting the hypokalemia and lowering the blood pressure. But the significant drawback, as many clinicians know, is its high incidence of hormonal side effects because it's not very selective. It also hits androgen and progesterone receptors. You see things like gynecomastia in men, menstrual irregularities in women. That can happen in 10% to maybe even 50% of patients, depending on the dose, and it's often a reason for discontinuation.
So for patients who can't tolerate spironolactone because of those side effects, eplerenone is the alternative.
Correct. Eplerenone is the preferred alternative in that situation. It's much more selective for the mineralocorticoid receptor. It largely avoids that binding to androgen and progesterone receptors, so you don't get the same hormonal side effects.
But there are trade-offs with eplerenone too, right?
Yes, there are. First, eplerenone is significantly more expensive than generic spironolactone. Cost can be an issue. Second, it may be somewhat less potent, both in terms of controlling really resistant hypertension and sometimes in correcting profound hypokalemia. You might need higher doses or more frequent dosing. The starting dose is usually higher, maybe 25 to 50 milligrams twice daily, and you often have to titrate up aggressively to achieve the same level of control as spironolactone. So for physicians managing these patients long-term outpatient, you really have to weigh the efficacy, the side effect profile, and the cost when choosing between them or deciding when to switch.
And regardless of which MRA is chosen, medical therapy isn't just about the pill, right? There are adjunctive measures.
Absolutely critical. Medical therapy must always be paired with adjunctive measures, and the most crucial one is rigorous dietary sodium restriction, aiming for less than 2 grams or ideally even less than 1.5 grams of sodium per day. The guidelines confirm and clinical experience shows that reducing sodium intake significantly enhances the effectiveness of the MRAs. It also provides an independent benefit in reducing cardiovascular risk in these patients. It's not optional, it's mandatory.
Okay, so MRA plus sodium restriction. It's really more than that we define what success looks like with medical management. We're not just aiming for a normal BP reading on the cuff.
No, absolutely not. Therapeutic success in medically managed PA means achieving 3 specific goals. Goal 1, normalization of blood pressure, obviously. Goal 2, correction of hypokalemia without needing any ongoing potassium supplementation. The MRA should handle the potassium. And goal 3, this is really important biochemically, achieving a rise in renin activity.
Okay. Explain why that rise in renin is so key.
That rise in renin activity is the crucial biochemical endpoint. It confirms that we are actually adequately blocking the mineralocorticoid receptor at the kidney level. It demonstrates that the MRA has successfully reversed that underlying suppressed renin pathophysiology that defined PA in the first place. The kidney should sense the blockade, and renin should come back up. If renin remains suppressed despite treatment, especially despite being on a good dose of the MRA, it strongly suggests the blockade is inadequate. The dose is likely too low, or maybe the patient isn't adherent, or perhaps they need even more sodium restriction.
That's a really key point for monitoring. Looking ahead, are there newer therapeutic options emerging for patients who maybe can't tolerate the current MRAs or still have persistent aldosterone excess?
Yes, thankfully there is progress. We are seeing the emergence of truly novel therapeutic options. This includes the development of aldosterone synthase inhibitors, or ASIs. Lorundrostat is one example that showed significant promise in the recent Target-HTN trial.
Aldosterone synthase inhibitors?
Yeah.
How do they work differently?
These ASIs work upstream. They block the final step in aldosterone synthesis itself, the step catalyzed by the enzyme CYP11B2, or aldosterone synthase. So they specifically reduce the production of aldosterone, ideally without significantly impacting cortisol synthesis, which is handled by a different enzyme, CYP11B1. This offers a completely new way to target the problem, distinct from blocking the receptor downstream. Also, things like epithelial sodium channel inhibitors, which target the downstream effect of aldosterone on sodium retention in the kidney, might represent a future expansion of our medical toolbox for some patients.
Okay, fascinating developments. Let's pivot now to the serious consequences of not diagnosing and treating this condition aggressively. What happens if PA goes untreated? The implications are profound, right? And they significantly elevate patient morbidity and mortality.
They really do. Firstly, untreated PA essentially guarantees persistent, often truly refractory hypertension. It makes long-term BP control incredibly difficult. But maybe even more importantly, focusing on the damage beyond blood pressure, that direct aldosterone toxicity drives massive cardiovascular morbidity.
The numbers are pretty stark, aren't they?
They are. Untreated PA confers something like a 2- to 4-fold increased risk of major adverse cardiovascular events, MACE, compared to patients who have essential hypertension matched for severity. That really highlights the independent cardiotoxic effects of the hormone itself, separate from just the pressure load.
And the risk for atrial fibrillation is even more dramatic.
Yes, the AFib risk is striking. It's often cited as being 4- to 12-fold higher compared to essential hypertension, even after you try to account for similar blood pressure levels. And this huge increase is thought to be directly linked to that aldosterone-mediated cardiac fibrosis we discussed earlier. It creates this arrhythmogenic substrate in the heart muscle.
And beyond the heart, there's significant kidney damage too.
Absolutely. Aldosterone promotes direct injury to the glomeruli and the tubules in the kidney. This leads to progressive chronic kidney disease, often progressing faster than you'd expect just from the hypertension alone. This direct renal effect contributes substantially to the overall cardiorenal syndrome we often see in patients with long-standing, untreated PA.
And we can't forget the morbidity related just to the persistent hypokalemia itself.
Right. You constantly face the risk of life-threatening ventricular arrhythmias if the potassium drops too low. There's the risk of acute ascending muscle paralysis. And even chronic issues like nephrogenic diabetes insipidus can develop, manifesting as that persistent polyuria and polydipsia because the kidneys lose their ability to concentrate urine properly.
Okay, so given these severe risks, systematic monitoring is absolutely mandatory, both during the initial stabilization phase and for long-term management. During the acute hospital phase, what are the key monitoring points?
In the acute phase, it's frequent blood pressure checks, obviously, and serum potassium monitoring is essential. We need to get that potassium up and keep it consistently in that high normal range, ideally above 4.0 mmPqL.
We also need to keep an eye on renal function.
Yes, monitor renal function, closely creatinine and eGFR, especially as we're correcting electrolytes and maybe starting medications like MRAs, which themselves carry a risk of hyperkalemia, particularly if renal function declines. And if the hypokalemia was severe initially, continuous cardiac monitoring with serial ECGs is warranted to detect and manage any potential cardiac arrhythmias until the potassium is stable.
Okay, that covers acute stabilization. What about patients started on long-term medical therapy with MRAs? How does the monitoring shift then?
For patients on long-term MRAs, monitoring becomes really focused on safe and effective titration. We recommend pretty frequent lab checks right after initiation or dose adjustments. Check serum potassium and renal function at maybe day 3, day 7, and again at day 14 after starting or increasing the dose. If things are stable after that initial period, you can usually transition to monthly checks for the first 3 to 6 months, and then maybe space it out a bit if they remain stable.
And why such rigorous monitoring, especially early on?
It's absolutely necessary to watch for hyperkalemia. That's the most dangerous potential side effect of MRA therapy, especially patients with underlying CKD or those on other meds that affect potassium. We also need to ensure adequate BP control, of course. And critically, as we discussed, we must monitor renin activity periodically to guide the MRA titration. Is the renin coming up? If it stays suppressed after, say, 3 months on a maximum tolerated MRA dose, we are likely failing to achieve adequate aldosterone blockade. We need to reassess the regimen or adherence.
Got it. And finally, for the patients who undergo adrenalectomy for unilateral disease, what's the focus of monitoring postoperatively?
Post-adrenalectomy, monitoring shifts mainly to confirming biochemical cure. We reassess PAC, PRA, and potassium, usually a couple of months out. We're looking for that significant drop in aldosterone and, importantly, the expected compensatory rise in renin activity, confirming the contralateral gland is functioning. But the hospitalists involved in the immediate post-op care must remain vigilant for that potential contralateral adrenal suppression, which, as we mentioned, can manifest as transient postoperative hyperkalemia that needs prompt recognition and management.
Okay, so wrapping this up, the central takeaway message for hospitalists seems really unambiguous. Primary aldosteronism is highly prevalent, especially in resistant hypertension. It's inherently high risk due to that non-BP-mediated organ damage. And it absolutely requires a structured, multi-step diagnostic and therapeutic approach.
Exactly. That approach starts with screening the right high-risk populations, then moving efficiently to confirmatory testing, often the saline suppression test, while carefully navigating those challenging medication washouts, followed by adrenal venous sampling for surgical candidates, interpreting it using those rigorous selectivity and lateralization indices we talked about, and then implementing subtype-specific management based on those AVS results.
And the key is that early, targeted treatment, whether it's the definitive approach of laparoscopic adrenalectomy for unilateral disease or aggressive MRA therapy combined with that mandatory dietary sodium restriction for bilateral disease, that treatment is critical to actually reverse or at least mitigate the cardiovascular and renal risks inherent in chronic aldosterone excess.
Absolutely. Treating PA effectively is probably one of the most impactful interventions we, as hospitalists and internists, can perform for these complex hypertensive patients. It prevents so much downstream morbidity.
We've established the precise therapeutic goals: normalize BP, normalize potassium without needing supplements, and achieve that crucial normalizing rise in renin activity with medical therapy. But as physicians always focused on outcomes and improving care, we also have to recognize where the current research gaps lie.
Right. We rely heavily now on ARR, PACE-C, and PRA to diagnose and manage these patients. But as we've discussed, these markers can be tricky. They're often confounded by medications, by volume status, even by variability between different lab assays. And this raises a really important question for ongoing investigation, a provocative thought, perhaps, for our listeners. Do we need better, more robust biomarkers? Maybe something that directly measures aldosterone's downstream inflammatory or fibrotic effects, or a marker less susceptible to acute fluctuations? Will something like that ultimately prove superior for guiding our long-term medical therapy, ensuring we're achieving truly adequate mineralocorticoid receptor blockade in every single patient, regardless of how complex their case is or how they respond to current MRAs? That's really a key area for future research in refining PA care.